Okay, what a big room. I'm quite nervous, so excuse my English. Thank you very much to the IPC for the invitation. I'm really honored to be here. When Dr. Bruce invited me to present a case, there was this particular patient I had in my mind, and I wanted to discuss the pain in psoriasis. Well, this is a 38-year-old male patient with psoriatic arthritis onset at age 25. 2 years later, he developed cutaneous plaque psoriasis. He's a former smoker. He had no family history of psoriasis. In 2012, he started with inflammatory low back pain. 1 year later, he started with peripheral arthritis of the knees, ankles, hands, and feet, and psoriatic plaque lesions appear on his legs. In 2015, he developed severe left hip pain. He was diagnosed with a vascular necrosis, likely related to a history of self-medicated oral steroids. In my country, patients can buy cortical steroids without any prescription. Rheumatologists started methotrexate, but this medication was very poorly tolerated by the patient. In 2020, infliximab was started, and this resulted in joint improvement, but only with partial skin clearance. This was the patient. He was on infliximab for 3 years with irregular administration. He developed later a secondary failure. In March of 2023, he started ustekinumab 45 milligrams with only partial skin response, achieving just a PASI 75, probably because he was overweight, but we could not increase the ustekinumab dose. 1 year later, he came back to my office. He was on prednisone 20 milligrams a day for over 6 months in order to relieve the pain he was having on his joints. He also he had weight loss, polydipsia, polyuria, and the skin lesions were flared and even more painful. Corticoid-induced diabetes were diagnosed and insulin was started. The plan here was to switch to adalimumab because that was the medication we had available at our service. But quantiferon returned positive. He started chemoprophylaxis for TB for 6 weeks, but he developed psoriasis flare with very widespread lesions in almost all of his body. These lesions were very pruritic and also painful. We started narrowband UVB, and the patient only had a DLQI of 7. By July of 2024, we were able to start adalimumab, and after 3 months, arthritis pain improved, but he developed new lesions in his face, and the plaques he had in his trunk and his lower limbs were more red, more scaly, and more thicker scales, almost very yellowish. So he also developed nail changes with destruction of the nail plates of most of his finger toes, and paradoxical psoriasis was diagnosed. We stopped adalimumab. We were able to start upadacitinib 15 milligrams a day with mild improvement of the skin, of the itching, and the pain and the arthritis. After 6 weeks, we were able to switch to ixekizumab. This was the patient with upadacitinib. We can see a mild improvement of the skin lesions and in the pain. And he started ixekizumab on January of this year, right in the day of my birthday. And after 10 weeks on ixekizumab, we can see that the skin was almost clear and the pain was much better. But at week 16, ixekizumab was discontinued for 2 months due to lack of availability, and symptoms again got worsened. especially joint pain and skin lesions on his legs. The plaques turn very thick, very hyperkeratotic, also almost like varicose psoriasis. And one of the patient quote in one of the latest visits, it was that he could not get off his car, his platform driver, for over than an hour, and that was really very frustrating for me. So finally, ixekizumab was restarted in July, 2 months ago, achieving pain relief within 3 days, and the picture in the right is how the patient is today. Well, psoriasis symptoms go beyond skin manifestation. This particular case involved axial arthritis, peripheral arthritis, and severe cutaneous manifestations that were very itchy and painful, including a paradoxical switch in psoriasis phenotype. Persistent pain prompted self-medication with corticosteroid, and this led to severe complication in this patient. Pain in psoriasis is not just a symptom, it is a daily burden that affects mobility, self-esteem, and quality of life. Accessing to care and treatment, even with systemic classic treatments and even more with biologics, is still very difficult in many countries, as in mine, and an early diagnosis and a proper treatment of very severe psoriasis is still a challenge in many places. Thank you very much.
Thank you very much for a very, very interesting case. And now we're going to listen to another case presentation from Josep Riera, who's a consultant dermatologist leading the psoriasis unit at the Department of Dermatology, Hospital Clínic de Barcelona, Spain. His work in psoriasis focuses on novel therapeutic approaches and identifying exposome-related triggers. His clinical expertise includes rare genetic disorders such as GPP and disorders of dermal differentiation. Dr. Riera is an IPC junior counselor.
Okay, we have a little bit of a problem with the slides. I'm gonna change this to mine. Okay, these are my disclosure of interest. Okay, so thank you everyone for being here the first day in a crowded room, Wednesday morning, and thank you for the kind introduction. So, as we've seen, psoriasis symptoms may change according to intensity of lesions, subtype of psoriasis, it's not the same PPG that plagues psoriasis, and as well, site of involvement. Regarding nail psoriasis, we would all agree that patients with severe nail dystrophy, onychodystrophy, such as like this one, will struggle with daily life activities such as wearing socks, shoes, or engaging in sports activities. However, we have patients there that they do not have these impressive nail changes, but they still suffer from a lot of pain. And I'd like to illustrate this with a case. This is a 59-year-old woman with no family history of psoriasis or psoriatic arthritis that she came out to consultation complaining of painful and very, very sensitive nail changes for the past 3 years. She had a lot of stigma. She was not showing her fingernails like this in the consultation until we asked her to. And she had been treated by her local dermatologist with topical clobetasol varnish for 6 months with no improvement at all, and for 2 years with methotrexate up to 17.5 milligrams weekly without almost no improvement in the nail psoriasis. On physical examination, we can see, and I'm sure all of you have seen these patients that have limited psoriasis in terms of BSA, because here we can see only a patch on the elbow and intertriginous involvement. And regarding fingernails, she had only 3 fingernails involved, but she had all the fingernails in her feet. However, the only ones that were painful were the ones in her hands. Her DLQI at that moment was of 4, which is not that high. And, well, if we have a closer look, well, we can see that there's onycholysis and salmon patch, but what's more impressive for me, it was that they were really painful when you palpated them or just touched them or just any subtle touch was very painful on her nails. So in our workout, we performed X-rays, which were normal. The acute phase reactant CRP, ECR were in the normal range. However, I thought, okay, maybe it's not only nail psoriasis. We all know that nail psoriasis is really related to enthesopathy. So I asked our room colleagues to see her, but they couldn't find any signs of PSA or signs of enthesopathy on ultrasound or psoriatic arthritis. We have an ultrasound in our department, so we perform nail ultrasound, and as you can see here, we can see a high Doppler signal on the nail bed or the nail matrix, but no signs of enthesopathy. So even though, according to the just numbers, the LQI, PASI, he was not, as we would say, completely eligible for biologics in our country. We started with adalimumab biosimilar, which is the one we start with according to local regulations, and she had complete response after 6 months. So we all have seen patients with nail psoriasis, and up to 80% of patients with psoriasis may have nail changes during their lifetime, but we have to remember that pain is reported in up to 50-60% of patients. Ultrasound of the nail matrix, the nail bed or the lamina, we can see their abnormalities, and it is true that they are more frequent in patients with enthesopathy or PSA, but they are not exclusive, as well as higher Doppler signal. And regarding DLQI, it might be limited. In fact, if you have a look at the questions, they ask only about skin, and that's why that's what the patient told me when I asked her about, okay, your DLQI is only of 4. What we have in the literature, we have a look at this systematic review with the reporting outcomes in randomized clinical trials on nail psoriasis. Almost all of them have used NAPSI, but regarding patient-reported outcomes, all of them used DLQI, but very few used specific index. What we have out there, there are several prompts, but the most used are NPQ10 and NAPA-QOL. The first one is short, it's very brief, it takes a few minutes, and it focuses on manual activities and functionality. It was validated in almost 800 patients, but only in France, and the validation is limited to other languages. On the other hand, we have NAPA-QOL, which is longer. It has three dimensions, physical, stigma, and daily life. However, it is longer, but it's validated in other languages. So it would be more suitable for clinical trials, while NPQ10 would be more suitable for daily life. And just to sum up, and I think I've adjusted to the 6 minutes, so we might have some time at the end of the session. We have to remember nail psoriasis burden is often underestimated, even for us, especially pain and stigma. Nail ultrasound may be helpful to see this inflammation on the nail bed, nail matrix, and as well to rule out enthesopathy or PSA, and that's something that maybe more rooms will do. The LQI does not fully capture nail impact, and for that we have nail-specific patient-reported outcomes. Thank you very much.
Thank you very much. Another very interesting case, and over to you, Jose.
Okay, good morning. So we move to a special population section, and we will start with psoriasis in darker skin tones. And it's my pleasure to introduce Ángela Londoño. She's the head of dermatology program at the University of Medellin, Colombia. She's presently the president of the Colombian group of psoriasis and psoriasis arthritis, and she's involved and has been involved in many clinical trials and practically any educational project, particularly in South America. Angela?
Thank you, Dr. Carrascosa. Thank you, everyone, for the invitation. This is my disclosure. Okay, this is one of the signs found on the beaches of South Africa, marking areas designated for use by white people. And it wasn't until 1991 that Nelson Mandela, thanks to his efforts, succeeded in abolishing apartheid. And why do I mention this? Because in dermatology, particularly in treatment approaches, we are still experiencing a form of separatism. Textbooks and therapies have been written for tested primarily in Caucasian populations. Today, I'll be sharing an overview of psoriasis in patients of skin of color. a crucial yet often under-discussed aspect of dermatology. While psoriasis affects people of all and racial and ethnic backgrounds, growing evidence highlights important difference across groups. Recent studies have shown that although the overall prevalence in psoriasis is lower in non-white populations, these patients experience more severe disease and greater negative impact of their quality of life. And here is our first problem, the lack of epidemiological data. In the Psoriasis Atlas, we can observe that in non-Caucasian populations or non-Caucasian countries, the prevalence is not high, but the question remains whether this is due to an actual lower incidence or a problem of underdiagnosis and underreporting. In US, also psoriasis is less prevalent in people with skin of color. You can see 1.9% in non-Hispanic Black and 1.6% in Hispanic populations versus 3.6% in whites. The studies consistently show this population experience more severe disease. Asia and LA, we see higher rates in erythrodermic pustular psoriasis. In Asia and Africa, lower prevalence of inverse psoriasis. Additional data in pediatric population, we can see psoriasis palmoplantar is the risk is 6 more black in black versus white population, and nail psoriasis also present more frequently in black patients, and diagnosis is often delayed. Referring to genetic difference, in studies conducted to identify associations between single nucleotide polymorphisms expressed in individuals with psoriasis, we can see the AL12B have been associated with psoriasis in risk in Asia, American, and European populations. The IL-23 receptor, which encodes the IL-3 receptors, have been also associated with psoriasis in risk in Caucasian populations. The additional IL-23A have been identified as a risk factor in psoriasis in German and Chinese patients. Referring in Latin America, in Mexico, several single nucleotide polymorphisms have been identified as increasing psoriasis ring, including variants in HLC and IL-12B. In Colombia, the TYK2 gene polymorphism is associated with psoriasis. These genetic insights guide us toward more targeted population-specific approaches. In skin of color, the classical signs of psoriasis can be harder to recognize. Erythema, for example, often appears gray, less pink, or purple violet. Here, we've seen an example of exaggerating scaling. In darker skin types, plaques tend to be thicker and scaling is more prominent, which can further affect a patient's self-esteem and comfort. And we can see, or we can take account key points. For example, scalp psoriasis is more severe and prevalent in Black and Asian populations. Diagnosis may be delayed due to hair textures and cultural practice like head coverings. And post-inflammatory pigmentarious change is a major concern in these patients. The change can persist even after inflammation resolves. These pigmentarious changes is due to the disease or the treatments and can be emotionally distressing. We must choose therapies that minimize this impact. For that reason, systemic therapies may be preferred early in these patients. Unfortunately, access to advanced therapies like biologics is unequal. Studies show that Black and Latino patients is less likely to be prescribed biologics, even when economic status is controlled. They also tend to rely more on topical treatments, which may not be sufficient for moderate to severe disease. Representation in clinical studies. People of color are underrepresented in psoriasis clinical trials. From 2010 to 2015, trials include very few patients of Africa of Hispanic descent. Barriers include lack of culturally adapted materials, strict eligibility criteria, and limited access to dermatologic care. As we move forward in improving dermatology care for all patients, it's essential to shift the way we describe and assess skin. First, we need to recognize that racial, ethnic, and geographic terms do not accurately reflect skin features. These labels often reinforce stereotypes and can be misleading in clinical practice. So we should avoid using them when describing skin characteristics. Instead, we should promote the use of objective scientific tools like colorimeters. This device allows us to measure skin tone with precision and consistency. To ensure truly inclusive dermatology care, we must take several key steps. First, it's essential to be comprehensive image database that accurately reflects the diversity of patients and various ways skin disease present across different skin tones. We also need to adopt, describe, inclusive, and culturally appropriate vocabulary that truly represents cutaneous diversity. Equally important is ensuring proper representation in patients with the skin of color in all dermatology educational materials. Without this, we risk misdiagnosis and equal care. Lastly, we must actively promote education around skin of color concepts, not just among healthcare professionals and researchers, but also the educators and general public. And we made a first step to correct these disparities. The IPC, aware of the importance of educating about psoriasis in skin of color, creates the Diverse Skin Type Working Group, a team I am very proud to be part of this. This group is dedicated to addressing unmet needs in psoriasis care to diverse skin types. It aims to improve knowledge in key areas such as genetics, epidemiology, clinical presentation, and treatment. A particularly valuable initiative of this group is the Photography Atlas, enriched by contribution from dermatologists worldwide. Thankfully, studies on biologics like secukinumab, ixekizumab, guselkumab, and risankizumab have begun to include Latino and Asian populations. But I want to highlight the work done by guselkumab in conducting the first placebo-controlled study to see its efficacy in patients with skin various tones. In closing, let's recap. These key points: psoriasis tends to be more severe in Asia, Black and Latino populations. Scalp involvement is more common in skin of color. Diagnosis is often delayed, and treatment disparities persist. We must recognize color variation in erythema and plaque presentation. Early systemic treatment may help prevent pigmentarious sequelae. Equity is access to biologic is essential to improve outcomes. Thank you, and I look forward for your questions.
Thank you, Angela. So we will continue with the next speaker, and it's my pleasure and my honor to introduce Professor Peter van der Kerkhof, who really needs no introduction. So he is and has been practically everything that anyone can be in dermatology. He has served as head of department in the Radboud University Nijmegen in the Netherlands. He is professor emeritus. He has led some of the major European dermatological societies, and we are extremely lucky by having him as IPC Chief Medical Officer. Peter?
Thank you so much for your kind introduction. These are my conflict of interest. And dear colleagues, I would like to draw first your attention to the world's population in general. That is, the population is aging. There is a global trend. In 2024, 800 million people were 65 years of older. But in 2074, that will double. And that means that 1 in 5 people in 2074 will be more than 65 years. And when we look at the people at 80 years, then actually the population of people more than 80 years will triple. Healthcare will increase tremendously in the area of care for elderly people, and especially also in the field of comorbidities, and especially our comorbidity that is actually metabolic health, there will in the general population be an enormous increase. And what is actually then the situation in psoriasis and elderly? We know that in people younger than 70 years, that hypertension, dyslipidemia, diabetes, and MACE are increased as compared to non-psoriatic persons. But in people more than 70 years of age and having psoriasis, we see that it is more normal there to have actually an abnormality in metabolic health than to be normal in this respect. And that means that when we are dealing with patients with psoriasis, in elderly patients with psoriasis, that we should pay attention to metabolic health. In contrast to the common belief, where in the past I have learned, well, when people are elderly, then the quality of life issue is not so much anymore an issue for patients with psoriasis. And on the contrary, actually in people who are elderly, actually the issues regarding quality of life are even more expressed. And what is it that actually is so important to pay attention to? That is, doctor, I would like to sleep better, or